side of the tumor, so the ducts. That's also, well, pretty much a big clue that it's a Phyllodes tumor. This is another example where you see that here you have regular ducts, all similar distance, and then all of a sudden the distance from one duct to the other becomes way bigger. So here the stroma overgrows it. Also, this is quite cellular, so this is already a lot of purple instead of pink. So this already looks highly like a Phyllodes tumor. If you look at really malignant growth, then this is a nice example. What I mean when it grows into structure in other pre-existing structures. When you look at it, the right top here, you see how skin looks in an if you put it on a microscope. So this is the upper layer of your skin, and this is the dermal layer of your skin, and here you see a hair follicle. So if you would follow this, you will get a hair out of it. But then here, this is tumor. This is not supposed to be here, because a Phyllodes tumor, normally when it's non-malignant, it doesn't grow in your skin. It grows in your breast tissue. So when it goes infiltrative like this in skin, then you know it's malignant. Also, when you see a lot of mitosis, it gets malignant. So these are all the mitosis only in this frame. This is a lot. So in a normal Phyllodes tumor that is benign, you would never see this. These are already 5 mitosis in one high power field, as we say in pathologist terms. So that's already a lot. And you have to count 10 of those fields to get the mitosis count. So you will easily get more than 10, because this is only one of 10 fields and you already have 5. So this is going to be a malignant Phyllodes tumor. But you can imagine these were all examples that we look at quite a big resection, but obviously we get biopsies, which then is already more difficult to see the difference between fibroadenoma and a Phyllodes, especially architectural. So the clover leaf is really difficult to see on a biopsy. So if you look at this biopsy, this is a Phyllodes tumor, and because there's quite a lot of stroma and also different amount of stromas. So here it's not so, it's quite pink, and here it's quite purple. So it varies in the biopsy, which is a clue for a Phyllodes tumor, because in a fibroadenoma it would be more the same. Here you have a normal fibroadenoma next to it. So it also has these ducts, but here the stroma is pretty much everywhere it's like the same. But here you can see it's quite dark here, and then there's quite a pink area here, and then it's dark again around the ducts, and that's quite specific for Phyllodes tumors, that the stroma condenses around the ducts. Again, an example, whereas more here there are more cells, and then you have areas where there's almost no cells, and then it's more cells again. And also in this biopsy you had a mitosis figure, so this is also a clue. So these are the things that pathologists look at, and obviously when Phyllodes is quite a difficult diagnosis to make. So if you think it is a Phyllodes, you always ask a colleague that's also a specialist in breast pathology to look at it with you. So you always have double reading at least, because it's a very difficult thing to do, because it's very rare. So are there any questions? I will see if I can stop sharing.
Great, thank you, Elise. I'm looking to Marloes and Marco to see if we can see any questions in the YouTube link. I don't think there are any. Well, obviously you're your talk was very clear, I think, I hope. So I think I will continue to share my presentation on the surgical treatment.
Yeah? And can you hear me?
Okay, I'll do it again.
Nee, hoor niet.
Yeah, and now? Can you hear me now?
Oh, we can hear you, yes, but don't see
Unmuted?
anything.
Myself?
Yes.
Not yet. Okay, try again. Screen share, desktop window. Here it is. Share. This should be it.
Yes.
Okay. So hopefully you can hear me now. If not, please send a message in the chat. Yeah, I think it's okay. So we can continue. Isn't this fun doing a webinar in 2022? What with all the technical difficulties, it's different from the last time we did it because now we have the YouTube link, so that's what sort of complicated things. But here we are now. So I'm a surgical oncologist at the Netherlands Cancer Institute, and I would like to present some slides on the surgical treatment of Phyllodes tumors. All, of course, under the guidance of the Phyllodes Foundation, which was initiated by Marco and Marloes van Astrid, who also organized this webinar as the best patient advocates for Phyllodes you can imagine. Well, about Phyllodes tumors, it's a very small proportion of all the breast lesions. It consists of only 2 to 3% of all the breast lesions. So it's relatively rare for doctors to see a patient with a Phyllodes tumor, especially in the smaller centers. Most of the Phyllodes tumors are benign, but there's a small proportion, about 10%, that is malignant, and there's a part that is in between, as Elise just explained, the borderline Phyllodes tumors.
We still see your first
It's mostly
slide.
seen in women aged between 40 and 50 years old and presents usually with a palpable lesion. So women visit their doctors because they feel something in their breast. Mostly the size is less than 5 centimeters, but it can grow into larger tumors, but on average it's about 3 to 4 centimeters. It is rare to present with a bilateral presentation, so a Phyllodes tumor in the right and at the same time in the left breast.
Frederieke, I stop you there because we can only
the best future from Phyllodes is that it's extremely rare to die from Phyllodes tumors, fortunately. That's because most of the Phyllodes tumors are benign, and if malignant, we can treat them with surgical resection. However, as Elise already indicated, there is a relatively high chance of getting it back and back and back and back. So a repeated recurrence can occur.
Ja? De slides blijven in Teams staan.
Oh, okay. So they see only my first slide and not the rest. Okay, try again. Open share tray. Share this. And I will try and to, because if I do this, I get this Teams slide. Is it still the same, Marco? Okay, then I will do it like this. It's a bit more. It's not as nice to look at it in this setting, but hopefully this is better. because everybody should be able to see my screen now. And it's not in a slideshow setting, but at least we can. We're time in the first slide.
Extremely rare.
Yeah, so that's good.
Is dat de tweede?
No, it's the fifth.
Yeah.
And I will just refrain from putting it in slideshow mode because evidently Teams makes a mess of things if I do that and it gets stuck. So you just now see my PowerPoint screen with the slides like this. So back to slide number 6, the treatment of Phyllodes tumors. Well, it's relatively easy in the sense that, well, you need surgery to treat it. So that's where I come in. And what do you do for surgery? Well, you have to remove it. And whereas in the past, people thought that you should do a very large surgery, we now know that only have to do an amputation of the breast if you have a very large Phyllodes tumor in 2 small breasts. So even if you have a large Phyllodes tumor, but you would have a very large cup size, then you could still do a breast conserving surgery. So as I said previously, decades ago, a standard surgical treatment would consist of a mastectomy, the removal of the entire breast. Then we evolved to do breast conserving surgery with a margin of over 1 centimeter, regardless of the tumor type. So both for benign and borderline and malignant tumors. Then the next step is that we try to achieve negative margins. I will go more into depth in the coming slides. And maybe in the future we will accept no margins at all, or who knows, maybe we can even refrain from surgical treatment for some Phyllodes subtypes. We're not there yet, though. For now, the surgery of the breast consists of local excision. Do we also need to remove the central node as we do in breast cancer? Well, that's also an easy question since the answer is no. What happens if you don't do surgery, if you don't remove the Phyllodes tumor? Well, for fibroadenomas, there's no indication to remove them, as they usually stop growing at about 2 to 3 centimeters. And they can also disappear by themselves, especially when you're postmenopausal. For Phyllodes tumor, it's a different scenario, since they will not disappear without any treatment. So standard treatment would be advised to remove the Phyllodes tumor.
As said before, if you remove it, it can occur. And when will it occur? On average, that would be about 2 years after the surgery. What we do know is that benign tumors will recur at a later time point than malignant tumor, and borderline, as expected, somewhere in between. What can be good to note is that if you start with a benign Phyllodes tumor and it recurs, it will recur as a benign Phyllodes tumor. Previously in the past there were some reports that indicated a malignant Phyllodes tumor after a benign Phyllodes tumor, but more recent studies have shown that this really doesn't or shouldn't happen. If the first diagnosis is correctly classified as a benign Phyllodes tumor, then if it recurs, it will be a benign Phyllodes. Elise has already showed you some recurrence percentages, but they differ widely across the studies, and most of the studies contain only small samples, so a relatively low number of patients. You see a list of percentages here for each 3 of the subtypes, but the most recent larger studies come up with, on average, these percentages. So less than 10% recurrence for a benign Phyllodes tumor, and about 30% for borderline, and slightly less than 20% for malignant Phyllodes tumors. Previously, we thought that it would mainly recur in younger patients with large Phyllodes tumors, and that if we have a wider margin, that would reduce the chances of recurrence. But most of the recent larger studies have indicated that the relation between size, and age is just not present. So even if you have a large phyllodes tumor, if you remove it, then it's not more likely to recur than a smaller phyllodes tumor. We do know, however, that malignant tumors recur more often and may be borderline as well. More importantly, what we know now is that the margin width does not influence the chances of recurrence. So even if you resect it with a small margin, there's not an increased chance of a recurrence. We do know that elements like mitosis and stromal cellularity are of influence, but more importantly, even in cases if you have a positive margin, so then the margin of the resection specimen is involved with phyllodes cells, it's even that does not increase chances of recurrence for the benign and the borderline studies in the most benign and the borderline phyllodes tumor in the most recent study. This, of course, should be taken into account when considering the surgical options. So this is a reference to the most recent and the largest study by Laura Rosenberger from Duke University, who may be considered an expert on phyllodes tumors. And the study included over 500 patients with phyllodes tumor. And what you see here is the cases of recurrent phyllodes tumor. So these were 60 patients who recurred with patients with surgery with the positive resection margins only. And what you see here is even in those 60 patients who had a positive resection margin, the recurrence rate was very low at 1.7%. And the same low percentages are seen for the borderline and the malignant patients. Although it must be noted that there were only 3 patients with positive resection margins in the malignant phyllodes group. Then continuing with the malignant phyllodes tumor, well, that's even rarer than the phyllodes, the benign phyllodes, with only about 2 cases in every 1 million women. Same age as told previously, and if recur and metastasize, it usually happens within the first 2 years. After about, if you look at the 5-year survival rate, it's in somewhere between 80 and 90%. So out of every 10 patients, 8 or 9 will have survived the disease. If metastasized, it does not metastasize to lymph nodes, but mainly to other organs, the lungs, and then the liver, the brain, the bones, but the lungs are the most predominant target organ. The risk of metastasis is higher with the specific tissue characteristics that can be identified within the malignant phyllodes tumors. Those are the factors that Elise has already mentioned, but even within the group of malignant phyllodes, these characteristics are of influence on the recurrence risk. So, to summarize, the surgical treatment of phyllodes for a benign lesion, you would really accept a positive margin. For a borderline lesion, you would aim for a negative margin. If you didn't achieve it, you should weigh the cosmetic pros and cons of a re-excision to discuss it with the patients. And if you have a malignant tumor, you should aim for a negative margin. There are no guidelines, at least not in the Netherlands, on the treatment and follow-up of phyllodes tumor. I would say that a maximum of 5 years follow-up is sufficient, given the fact that the recurrence mostly happen at 2 to 3, maximum of 4 years, and we would do that with an annual mammography and ultrasound. These are the current NCCN guidelines, and here you see Laura, and it's more or less the same as I discussed just now regarding the surgical treatment. In the NCCN guidelines, the follow-up is a bit shorter at 3 years, but a little bit more extensive as they do an ultrasound every 6 months rather than every year. We are trying to develop a guideline, of course. In the Netherlands, we will do this via a national agency, and the phyllodes has recently been designated as a subject that should be included in the guidelines. So I would expect there to be a guideline within the next year. And in Europe, we work with a consortium of Phyllodes, well, not necessarily experts, but people interested in this specific disease. And there was just done a very large international survey in which a total of almost 450 patients, physicians from 17 countries participated. So that was a very high participation grade, and we are now busy analyzing the results. I guess that was it for me. So thank you for your attention. I will stop share my presentation now. So, and Manus informs me that she has a question from the chat, which is...
There's a question if it's possible that fibroadenomas morph into Phyllodes tumors.
I will repeat the questions for the viewers. The question is, could fibroadenomas morph into Phyllodes tumors? As far as I'm aware, they cannot. Elise will hopefully confirm this.
Yes, no, I said it in my presentation as well.
You're mute, Elise.
I'm not muted.
Oh.
I think, can anybody else say if they can hear me? I know Frederieke can't hear me, but can the rest hear me? Oh, yes. Thank you. Yeah, so as I said in my presentation, it looks like each other, but it's a different tumor. So you can't have a fibroadenoma evolving in a Phyllodes tumor. That's not possible because it's not the same tumor. It's a completely different thing, although it looks like each other.
Well, thank you, Elise. That was a clear answer. Any other questions in the chat, Manus?
Some talk of like when it starts out as benign, can it evolve into, when it reoccurs, into borderline or malignant over time, or is that not possible?
Well, the question here is whether a benign Phyllodes can evolve over time or recur into as a borderline or a malignant Phyllodes. As I showed that we used to think so, but more extensive analysis in larger series does not really confirm this. So it should not happen if the initial diagnosis is correct. So if you are benign, if you have a benign Phyllodes, you're stuck with a benign Phyllodes, which in a way is positive, of course. Then I would like to give the floor to Astrid Scholten, who is a radiotherapist at our institute.
Thank you. Try to share my slides. Can you see my slides now?
Yes.
Okie-doke.
Yes.
Good afternoon. I'm a radiation oncologist, so I'm going to tell you something about the role of radiotherapy in Phyllodes tumors. Not much happening. Yeah. Elise told you this before. Most of the Phyllodes tumors are benign. Approximately 40% are borderline or malignant, and those are the ones in which radiotherapy might have a role. So the local recurrence risk after resection, it's a bit high, 65, should be 25, my apologies, but cornerstone of the treatment is a radical surgical resection. Like Frederieke said, does it have to be more than 1 centimeter? Can you have less margin or even a positive margin? And the question I would like to address is there a role for radiotherapy? When we look at publications about radiotherapy in breast cancer, you see that there are very, very large trials done, over 10,000 women, but these are all about breast cancer. When you look at publications about Phyllodes tumors, it's about 37 patients, 48 patients, so quite limited. I just checked the publications last year, so 21 scientific publications, and you can see that for breast cancer there were over 12,000, for Phyllodes tumors only 61. So there's a lot to be done. Of course, it's also due to the rarity of the disease, but it is really limited, the amount of publications about the subject. Now, what do we know? There's one nice prospective study, including 46 patients with a borderline or malignant tumor, included in 30 different institutes, so that also illustrates the rarity of the disease. They were all treated with breast-conserving surgery and all received radiotherapy. And the margin was quite variable. It had to be radical, so approximately half of the patients received a resection, but these are the margins for the primary resection. So a lot of those have a margin of less than 1 or 2 millimeters. They found no local recurrences with a long follow-up of almost 5 years. The Rare Cancer Network in France investigated the outcome of approximately 160 borderline and malignant Phyllodes tumors, mostly treated by breast-conserving therapy and hardly any radiotherapy. Only 9% of patients received radiotherapy. And prognostic factors that they found for local control was mentioned before, the benign versus borderline malignant tumors, the margin status, but also whether or not radiotherapy had been given. Radiotherapy significantly improved local control in these patient subgroups. A publication of last year with approximately 60 patients, most treated with breast-conserving surgery and 50-50 radiotherapy or not. And you see the same when you look at prognostic factors and the effect of radiotherapy. It significantly improves local control. There was a meta-analysis taking into account approximately 6 articles with over 2,000 patients, borderline and malignant Phyllodes tumors, and they all show the same trend. You see here that radiotherapy improves local control, not always significantly, but overall it gives an improvement. So that's good news. The question is, should we give everybody radiotherapy? There is also another side of the treatment, and those are the side effects of radiotherapy of the breast. Those are tiredness, rib pain, and fibrosis of the breast. The first 2 are most often transient, but fibrosis is often permanent, and that differs enormously between different women. Here you see really different situation, 2 different women, one hardly any fibrosis or cosmetic change in the breast, but the other has a lot of fibrosis, a bit of pain of the breast, and malformation. So we don't know yet whether or not to give radiotherapy for all Phyllodes tumors. Some say post-operative radiotherapy after breast-conserving surgery needs to be considered, irrespective of margin status, whereas others state that with a microscopically negative margin, you can just wait and see, and no adjuvant treatment is indicated. Our national guideline, Frederieke just mentioned it, only says treatment of a Phyllodes is a wide excision. That's all. Now, we're working on a new guideline, so hopefully next year we can show you some more information, because the guideline of the soft tissue sarcoma doesn't mention the Phyllodes tumor at all. Närlich and all investigated what the trends were over time in using radiotherapy for malignant Phyllodes tumors. And as you can see, the use of radiotherapy has increased over time. So it's almost 20% of patients nowadays with breast-conserving surgery or a mastectomy receive radiotherapy. In conclusion, there are no randomized trials on radiotherapy for Phyllodes tumors, and of course especially not about the dose of radiotherapy that should be given if you give radiotherapy. Studies that have been published are mostly small. We see that radiotherapy decreases the local recurrence risk without an effect on overall survival, but it does have a risk of side effects. So it's all about the balance between the costs and benefits, and of course the patient preference, whether or not to give radiotherapy. And in my opinion, you should consider radiotherapy and discuss it with the patient for every borderline and malignant phyllodes tumor. After breast conserving surgery, I think you should discuss it with all women, and with close or even positive margins after mastectomy also. In that case, it should be discussed with the woman herself. Thank you very much.
Thank you, Astrid, for your very clear presentation. I'm looking at Marloes to see if there's a question in the chat.
Astrid mentioned the side effects. What are the main side effects?
Astrid, the question is what the main side effects are of the radiation therapy.
That's the tiredness, the pain of the ribs, and the fibrosis of the breast.
And any other questions in the chat?
No, not yet.
Then I'm gonna put the camera on and put Marloes back on. Here she comes.
Well, to sum it all up, I think we've had some very clear presentations. I would like to thank each and every one of the participants for joining us today. Everyone who's watching, I would like to thank them as well for joining us today. I hope until next time.
I think there's one question in our chat in the Teams.
Oh, yeah, there it is. It is
About medical possibilities.
The medical possibilities when you have a metastasized phyllodes tumor. Well, that's not an easy question. The short answer would be that there are no effective treatments, since unfortunately phyllodes is not very susceptible to chemotherapy. So it will be discussed with patients in this situation, but unfortunately it will not be very effective. In the sarcoma treatment, there are new drugs being developed, as in all cancers, but I'm not aware that there are effective treatments currently for phyllodes tumors, for malignant phyllodes tumors. Maybe Astrid or Elise will know more about this, but I'm afraid that it's a very, very
usually when you have a malignant phyllodes tumor, it pretty much looks like a sarcoma. So an undifferentiated sarcoma. So that's a highly malignant tumor. And I don't think there's anything specific apart from no, I don't think there's anything specific. I don't know. I don't think they give you chemotherapy or anything. I don't know. But when it's to the lungs, it's quite, maybe when it's only one metastasis, you can radiate it. I don't know. That's a question, obviously, for Astrid. But she's also known in sarcoma care. So maybe she knows a little bit about it.
Yeah, when it's just a limited amount of metastasis, and with a long interval, we do irradiate to high dose the lung metastasis. And if it's more than just a few or very rapidly evolving, then palliative chemotherapy is an option. But that's always discussed with the patient, because the effect is minimal and the side effects can be quite impressive. Yeah.
Thank you, Astrid and Elise. There are no other questions. Well, Marloes has already thanked everyone, so I will not do that again. But I hope everyone has a good evening and a good morning if you're not in Europe.